Cool. So, morning everyone, and welcome to our series on our new community health profiles, overviewing the health inequalities and health needs of different community groups. Today, we're going to be focusing on the findings from our Central and Eastern European profile and discussing some of the health inequalities experienced by this group and what some of our next steps are. So, I'm going to start the presentation by giving an overview of how we've defined the Central and Eastern European population within the profiles, the data that we've used, the limitations of this data, and some of the demographic and geographical information. Then I'll discuss the key findings and the specific inequalities that we've identified within the profile. And finally, I'll talk about how the profiles can be used and our upcoming deep engagement partner opportunities before we finish with a bit of a short Q&A and any opportunity to discuss some of the stuff. So before we start, can I just ask everybody to make sure they're muted and any VPNs, turning off any VPNs just to ensure the webinar runs smoothly without interruption, that sort of thing. But if you do have any questions throughout, please feel free to put your hand up, unmute, stick it in the chat. And there should also be an anonymous Q&A section within the Menti that we're going to be using today, if you want to pop any questions in there. The slides from today are going to be recorded and they'll be uploaded to the Birmingham City Council website and to Healthy Brum YouTube, and we'll notify you via email when the recording's available. It should be tomorrow morning, maybe later tomorrow. We're going to be using Menti during the webinar today, just to get your feedback and provide some of the opportunity for interaction. So you're not just listening to me talk about inequalities for an hour. So we'll just get everybody set up on that now. You'll be able to see the QR code on screen and somebody will put the number in the chat. We're going to be asking some questions where you might need a bit more time to think about or write out your answer. So can I ask someone in the team to pop those questions in the chat as well? So the first Menti question is, what's one thing you're looking forward to learning or discussing in today's webinar? So if you could go on to the next slide, please, Jordan. So with this, we're just trying to gauge where everybody is in terms of their understanding of inequalities in the community. So wait a minute or so, just to get people's responses to that. Yeah, so people wanting to know how they can engage with different communities in healthcare, wanting to get some more knowledge and understanding of the Central and Eastern European community in terms of inequalities. Yeah, what we know so far. Learning about how health inequalities are going to be addressed in some of the work. Yeah, and you're in the right place. That's what we're planning on talking about today. So that's all good. I'll now move on from this Menti question just to give a bit of an intro to the community health profiles and explaining the Central and Eastern European community profile and the background to it. So what are the community health profiles? They're desktop pieces of research which summarize the published evidence, the grey literature and population survey data on different communities. They provide a snapshot of the physical and mental health of a specific community, as well as the lifestyle, behavioural and wider determinants of health inequalities. Each profile looks at the health inequalities throughout the life course, and the information is presented in themes according to the key priority areas within the health and wellbeing strategy. So the idea behind the profiles is to move away from acronyms such as BAME and LGBTQ+, which tend to homogenize communities together and overlook some of the huge differences in the health outcomes between these population groups. So in addition to the profiles, there's also a range of census infographics that are shorter and more accessible summaries of the health inequality information. You can also find out more about the background of the profiles at a link to a video that somebody will put in the chat, please. So I'm now going to talk about how we've defined the Central and Eastern European population within the community health profiles and what some of the limitations of that are. So the data that we've used and the limitations of it as well. Yeah. Within the 2021 census, there isn't a wider ethnic category that accurately reflects the Central and Eastern European population. So whilst there is an option for people to give their specific ethnic categories, such as white Romanian, the detailed ethnicity data couldn't be used for analysis alongside other variables, and that kind of limited how useful it was. So because of that, within the profile, we've used the white other ethnic category. And from the analysis that we did of the census data, we determined that over 50% of the white other ethnic category were people that were born in Central and Eastern European countries or had Central and Eastern European heritage. And over 80% of people who were born in Central and Eastern European countries and lived in the UK identified as white other. And that meant that it met our inclusion criteria. And where possible, Central and Eastern European country of birth data was also used, but that's limited because it only shows us the experiences of first generation Central and Eastern European migrants. Where available, the data and studies from smaller scientific journals on specific countries and communities within Central and Eastern Europe have also been used to support the data. We recognise that there's issues with how data on the Central and Eastern European population is collected. So the council have developed a demographic data collection tool in collaboration with Birmingham residents. And that tool suggests using Central and Eastern European as a separate ethnic category rather than white other, as well as providing the option for people to write in their specific country of heritage. That provides a clearer overview of populations, and it also allows for specific breakdown by country of heritage in a way that doesn't exclude second and third generation migrants and so on. But with all that said, there are limitations with using the white other ethnic category as well. So firstly, the white other ethnic category aggregates lots of ethnicities within white other. So besides Central and Eastern European people, the other significant groups in the white other category in the census were Italian, Spanish, Portuguese, French, German, American, South African. So inclusion of those other populations limits how representative white other is of Central and Eastern European experiences. And particularly since most of those countries, migrants from those countries are fairly affluent, it can sort of distort some of the health inequalities experienced by Central and Eastern European people. And whilst over 80% of Central and Eastern European people identify as white other, it's also important to note that some people don't, and therefore using that category excludes their experiences. The white other category is also used inconsistently across different studies. So in some smaller studies, it usually includes white Irish and Gypsy, Roma and traveller communities as well, but it doesn't in the census. And that as well can reduce how representative this category is of the population. And it also prevents effective analysis across studies. So that's just a caveat to the white other data that we've used, and it's explained more in detail in the profile as well. Also, within some data sets, such as the GP patient survey, data isn't adjusted for other variables such as age and gender, which can also impact how health outcomes are understood. It's also important to note, just before we move on to the next slide, that all of the profiles and some of the data sets are limited in how they understand intersectionality. So somebody's identity and their experiences won't just be linked to their Central and Eastern European identity. There's also their age, gender, sexual orientation, faith. People might have disabilities as well. And all of those things can compound with ethnicity to have an impact on people's health outcomes. So with all of that said, and I know that was quite a large disclaimer, we're now going to look in more detail at the demographics of the Central and Eastern European community in Birmingham. So the approximate total Central and Eastern European population within Birmingham is 26,754 when we total the more specific ethnic categories from the 288 category detailed ethnicity data set. Within that data set, the largest categories were white Polish, which is roughly 0.7% of the Birmingham population, white Romanian, which is roughly 0.6%, white other Eastern European, 0.2%, and other Romanian, which is 0.1%. However, 26,000 is a conservative estimate. The number would be greater if we also consider Central and Eastern European people who list white British as their ethnicity, which was from the analysis about 10% of Central and Eastern European born migrants. So country of birth data shows that there's approximately 34,000 first generation Central and Eastern European migrants in Birmingham. But it's basically from the data, it can be hard to determine how many Central and Eastern European people are in Birmingham, and that is one of the issues with it.
Ja tego nie widziałam wcześniej, nie wiem,
Sorry, can I just ask everybody to make sure they're muted as well? Cheers, thank you. So multivariate analysis for detailed ethnicity data isn't available. So to avoid using the less representative white other data, country of birth data was used instead. And from this data, we can see that 71% of Central and Eastern European people identify as Christian, and 17% identify as having no religion. And then when we look at English language proficiency, we can see that 26% had English as a main language, 59% can speak English well or very well, and 14% cannot speak English well or at all. And in terms of the age profile of the community, we can see that 28% are 25 to 34, 39% are aged 35 to 49. And that's a significantly larger proportion than the general population for this age range. And there's generally less of the population who are over 50 or under 25. But it should be noted that when you use country of birth data, second and third generation migrants tend to are excluded, and they would typically be younger. So it might look, the age profile might look different if we use that. So now if we look at the geography of the Central and Eastern European population, it's useful to understand the geography of the population because that can help to inform place-based community events or health interventions. And although where people live might not be where they engage as a community as well, and you should use a mixture of the data and community intelligence as the best approach. A useful tool for understanding geography of the Central and Eastern European population is the 2021 census mapping tool. And if you've not used it before, I highly recommend it as a way to understand variables visually. The tool allows you to look at variables at a middle layer super output area level, which is just a complicated way of saying an area that's approximately 2,000, 6,000 people. And you can also look at output area level, which is an area with average size of about 310 residents. But how specific an area you can look at is determined by the data that you use, usually because of data protection and disclosure reasons as well. But using the tool, we can see that middle layer super output areas with the largest population densities of white other are Central at 14.8%, Ladywood Summerhill at 13%, and Five Ways North at 12.2%. But as discussed, the white other data can be limited. So when we look at geography from Central and Eastern European country of birth, we see that the wards with the largest proportion of Central and Eastern European population are Stockland Green, Ladywood, Soho and Jewellery Quarter, North Edgbaston and Erdington. However, where the communities are varies depending on the different specific groups within the Central and Eastern European community. So the Romanian population is largest in Soho and Jewellery Quarter, whereas the Polish population is largest in Stockland Green and Erdington. Hopefully you can see from this previous section that accurately identifying and understanding the size, demographics and location of the Central and Eastern European community within the existing data can be pretty difficult. and there's a significant need for improving data collection. But with that said, I'm now going to go on to discuss some of the health inequalities that we've actually identified within the profile. But before we do that, we've got 2 Menti questions for people to answer. So the first one being, how do you currently use health data to inform your work or decisions, making your decision making related to address health inequalities? So we'll just wait for people's responses to come in through that. So I'm just having a quick look at the questions in the chat. Yeah, so Magda, there is data for Handsworth and Perry Bar in terms of like the size of the population there, and that will be included within the profile. And you can also access that through the 2021 census as well. But those 5 that I listed are the largest wards in terms of proportion for those community groups, as far as the data shows anyway, which, as I've said, is possibly one of the issues with that. So how do people want to use the data? So yeah, info from patient feedback and interpreters. Somebody's recently mapped out patients using their postcode to identify where most of them are. That's useful. University healthcare for like research applications. Yeah, so there's loads of different ways people are using data for this community. So if we move on to the second question, that's just wanting to know how confident people are in identifying the health needs of the Central and Eastern European population at the moment. Cool. That's good. So around like 2.7, so middle level of confidence at the moment, which is fair enough, and hopefully we'll try and improve that over the course of the webinar. So now I'm going to move on to actually talk about some of the inequalities that we find within the profile itself. So for this section of the webinar, in nature of just like time, I'm only going to focus on one key piece of data or one study from each of the sections within the profile, just to show the types of findings that are available. And where possible, the presentation is going to look at what areas had the best quality data for that particular section. So we use large-scale studies, national databases, and we'll present on the findings that were usually most specific to Central and Eastern European populations, and try and avoid some of the studies that just use other white. And the data that's presented in the slides doesn't necessarily reflect the biggest areas of importance in terms of health inequalities. It's just the areas that we felt were strongest in terms of the data. And we won't provide a comprehensive understanding of all of the health needs of the Central and Eastern European community. It's more of just a start point. And I'd encourage everybody to go and read the full profile and look at some of the data sources that are in there to try and understand it a bit better. With that said, the first section looks at inequalities in children and young people and how to get a best start in life. So looking at dental decay, an oral health survey by Public Health England looked at the prevalence of dental decay in 5-year-olds. And this showed that the percentage of children with 1 or more teeth with visually obvious dental decay, Eastern European children had the highest experience of dental decay at 49%, compared to 23% of the total survey population. And this is really important because good oral health can support children's overall health, cognitive development, and dental infections can lead to later chronic medical conditions in later life, like diabetes, stroke, psychosocial consequences like self-esteem being shy, that sort of thing. And the oral health survey also reported on the number of affected teeth among children with decay. So on average for Eastern European children, 5.1 of people's teeth was affected compared to 3.4 average. There's limited qualitative research to actually identify the reasons why oral health was poor. And that's, I guess, where there's a need that needs to be filled. And that trend was also mirrored in the adult population for Eastern Europeans as well. So now if we move on to look at mental wellness and balance, this section looks at mental health of the population, as well as things like substance use. And we can see that mental health needs of the Central and Eastern European population are often overlooked as they're grouped under white or white other categories, and that kind of silences and makes the community invisible within data. However, there are several smaller scale qualitative studies that have identified things like discrimination, xenophobia, as well as factors relating to migration stress, such as language barriers, financial difficulties, and unfamiliarity with local culture as being causes of poorer mental health within Central and Eastern European communities. So the range of smaller studies has shown that there's significant experiences of discrimination within the CEE community. And those studies found that whilst many Central and Eastern European people are white and majority group passing, they often experience a kind of othering and racialization, and they're often categorized as white other. And this otherness emerges based on intersections of ethnicity with things like skin color, nationality, language, social class, and rising anti-immigration discourses, particularly in the UK. So, for example, in one study, 77% of Central and Eastern European young people had experienced racism and xenophobia based on their nationality, and 14% from that study had experienced it often or very often. And these experiences are exacerbated by wider anti-immigration discourse. So in another study, 49% of Central and Eastern European people felt that they'd experienced increased racism since the EU referendum. Now, there are a lot of other studies that look at mental health and suicide and substance use within the Central and Eastern European population, and those are covered in the profile. But for this presentation, I won't discuss those, but I'd encourage you to go and have a look at those. So moving on to the next section, which is healthy and affordable food. There's very limited data on the Central and Eastern European population in terms of nutrition. But there was a study in Luton in 2018 that sought to understand the eating behaviours and barriers to healthy eating within the Polish community. And that study identified the barriers including like the convenience and accessibility of unhealthy food compared to the financial costs, the time, and the planning required in preparing healthy meals. So those were some of the barriers to eating healthily within the community. And the recommendations from that study to improve nutrition within the community included improving communication and changing associations with the term healthy food and what it is, as like a lot of nutrition guides out there are very sort of centered around a particular like white British type of cuisine, and that's not always appropriate for everybody. Oh, they also suggested improving education around easy and affordable options for food through educational cooking programs. So, for example, cooking classes on cheap, quick, healthy meals specific to Central and Eastern European cuisine. And they also suggested more work around policy and planning in nutrition for this community. So working with retailers to adjust the visibility of junk food, working to get planning permission to consider like the location and the number of takeaways in different areas and how that affects different communities, and also working with local restaurants to offer healthier options as well. So now move on quickly to talk about physical activity. Sorry, bear with me, there's an ambulance going past my house. Yeah, so if we look at physical activity, the Active Lives survey shows that 65% of the white other population in the West Midlands were physically active, which is more than the white British population at 60%. And that's based on 150 minutes of moderate physical activity. So that's anything that raises the heart rate, such as a brisk walk or cycling, or 75 minutes of vigorous physical activity, which is high intensity exercise, such as running. But it can also be useful to understand what sports are popular within different communities when planning physical activity interventions. So within the white other population, the most common activities were walking for leisure, running or track and field, fitness classes, cycling for travel, swimming and football. But as I have said before, the white other group is an aggregation. So when we look at sport within Central and Eastern European countries, sports such as ice hockey, football, basketball, volleyball, gymnastics and winter sports are particularly popular. So there was a study by Sport England, and it showed that for the white other group, 4.8% of the population, the white other group made up 4.8% of the population, but 13.4% of Central and Eastern of white other people played volleyball, 9.9% did gymnastics, 8.4% did basketball, 8.2% did cycling for travel, and 7.3% did snow sport. So it shows that those sports were far more popular within the community as well. Another study explored barriers to participation in sport among Central and Eastern European migrants, and that found that things like cultural differences and language barriers, as well as experiences of discrimination, can increase alienation and reduced attendance in different sports clubs and activities. So that's something that needs to be addressed in terms of improving physical activity as well. Moving on to living, working and learning well, that looks at some of the different wider determinants of health for adults. Within the 2021 census, 24% of the Central and Eastern European population, or 24% of Central and Eastern European born migrants experienced deprivation under the housing dimension. That's compared to 9% of the general population. So a household is classified as deprived in the housing dimension if the household's accommodation is either overcrowded, in a shared dwelling, or has no central heating. In terms of overcrowding, 19% of Central and Eastern European born migrants in the UK lived in overcrowded households, and that's compared to 6% of UK born migrants, not UK born migrants, UK born people. In terms of private renting, 61% of Central and Eastern European population born in England and Wales lived in private rented accommodation. That's compared to 16% of people with UK country of birth. And private renters on average spend higher proportion of their household income on rent compared to other tenures, such as social renting or people that own their houses. When we look at deprivation by different barriers to housing, 17% of the white overpopulation in England and Wales lived in the top 10% most deprived neighbourhoods in terms of barriers to housing. So for the index of multiple deprivation, those barriers include different distances to services such as post offices, schools, GPs and supermarkets, household overcrowding, homelessness and housing affordability. And all of those things create barriers to quality housing and have indirect impacts on your health as well. In terms of then people seeking support around housing, generally findings were that migrants in private sector housing found it difficult to access support, such as like payment. And there was a 2004, so it's an older study, but 2004 study in Glasgow with Czech and Slovak nationals that highlighted a heightened sense of insecurity in everyday life that arises from common experiences of rejection on like benefits applications and applications for housing as well. And I'd imagine that is something that continues even now. When we look at the quality of housing, there's not any specific Central and Eastern European data, but there are close links with renting in the private sector and poor quality housing. So when we consider that there's a much larger portion of the population that rent, you can imagine that there's more inequalities there as well. Now moving on to look at the protect and detect section. This section covers a lot of different areas, but we focused on some of the barriers to accessing UK health services within the Central and Eastern European community and what the recommendations are for improvement. So some of the barriers to accessing UK health services for the Central and Eastern European community are challenges navigating the UK health system, which can differ quite a lot to different people's countries of birth. Low trust in the quality of services and the quality of support people will receive in services, potentially because of experiences of discrimination in the past as well. Another barrier can be around transnational use of services. So it's quite common for people to choose to travel back to their country of origin for healthcare as well, possibly because they've got more trust in the quality of that. Another barrier is around language and literacy barriers as well. So if you have lower English language proficiency, it can create a barrier to navigating. And yeah, as somebody's just mentioned in the chat, there's often poor, there's not a great offering for interpretation services as well, which can just either lead to negative experiences within healthcare or just put people off going altogether. So it's recommended that healthcare providers take the time to explain systems to service users and how to navigate them. And it's important to improve community access to credible information as well. It's also important that it was reported that engagement is more effective when using outreach services like community groups and engagement through things like community centres and like the church. The protect and detect section also includes lots of discussion of inequalities in vaccination, sexual health, and routine screenings, as well as oral health and prevalence of different infectious diseases. I won't go into those now, but there's some good quality data there with the Central and Eastern European community. So I'd encourage people to go and look at that. Moving on to the last section in the profile, which is, I should say, there is an aging and dying well section within most of the profiles, but data was incredibly limited on the Central and Eastern European population in terms of experiences of aging and end-of-life care. So there is a section in the profile, but it's short, so I'm skipping over it today. But if we look at the section on contributing to a green and sustainable future, that looks at experiences of environmental health and things like pollution. So when we look at data on pollution mapped against geographic distributions of communities in the 2021 census, we can see that approximately 22% of the white other population live in the 15 most polluted middle layer super output areas in Birmingham. And that's compared to 5.4% of the white British population. So it's 4 times the population. And that's significant, as an estimated 6.2% of total mortalities in Birmingham in 2021 were attributed to air pollution. So yeah, considering that a large proportion of the population live in heavily polluted areas, you have to think about the long-term impact that that's having on people's health. I've covered like quite a lot of the inequalities, but there are many more that are discussed within the profile as well. So some of the other significant health inequalities that haven't been covered include things like higher rates of use of mental health services. So in 2020 to 2021 in England, there were 5,000 or nearly 6,000 per 100,000 white other people who used NHS mental health services, compared to 4,000 in 100,000 of the general population. There's also Eastern Europeans had one of the highest suicide rates within the UK as well. And within Protect and Detect, there's significantly higher rates of hepatitis B. So in a 2014 migrant health guide, it showed that Central and Eastern European community had moderate to high rates of hepatitis B. It was between 5 and 10% of the adult population, compared to 0.3% of the UK population, which is significantly higher. So in terms of to conclude on like the different inequalities within the community, the profiles provide an evidence summary of inequalities and can be used to develop different solutions. However, it's not an exhaustive document that's going to map all of the experiences of the Central and Eastern European population. And it's also important that we consider intersectionality and the influence of other aspects of people's identity when making decisions regarding services, resources, and healthcare. I'm now going to move on to talk about we're going to do a quick Menti, and then I'll move on to talk about some of the engagement and community work that we're doing off the back of these profiles. So just another quick check-in on the Menti of how confident do you feel in identifying the health needs of the Central and Eastern European population. I've kind of covered quite a lot of the inequalities, but as I say, there's a lot more. Hopefully it's improved some people's understanding, which it looks like it has. So that's good news. Cool. So we're on about 3.5, which is an improvement from what it was at the start of the session, which is good. So now I'm going to move on to discuss some of the next steps that we're taking around the profiles. So all of the profiles are currently in a draft version, and they're all open to being edited at the moment. So we encourage all webinar attendees to read the profile, and we'd appreciate people's feedback. So if you feel like there's any inappropriate language that's used, or important reports or data sets that aren't included, then please do let us know. And yeah, let us know the profiles. Sorry. All of the profiles followed the same outline template and had like the same sections, but that might not be appropriate for every community. So if you feel like there's a section that should be added, do let us know. And if there's like a health need or a key community identified area of importance that hasn't been included, you can drop us an email and we'll add this to the final report. For example, we had some feedback about gambling and the impact of that on mental health, and maybe that should be added in. So we're looking at doing that now. We're also happy to set up feedback sessions and one-to-ones if people want to discuss further. And if your organisation works with Central and Eastern European community, or you offer a specific health service to that community, we're happy to add your contact details into the appendix of the report as well, so it can be used for signposting. In terms of how we want the profiles to be used by people, we encourage everybody to read them to build their knowledge and their understanding of health inequalities in the community. We'd also encourage everybody to share it widely with their colleagues, their wider organisation, partner organisations and networks to encourage them to do the same. the profiles can be used as a tool when engaging directly with communities and to support them in advocating for change around some of the inequalities that I've mentioned. We want people to use the data and the evidence in the profiles to inform and support new health interventions, policies, and service proposals, and to justify further primary data collection to actually fill some of the gaps that we've highlighted. And we're also keen for people to use the profiles to provide rationale within funding bids as well, because I think the inequalities that have been highlighted need to be addressed, and we're hoping that the data that we've found can provide support for doing that. But yeah, the profiles only provide headline data within each section, and to find out more, there's plenty of other sources that we've listed in the references that can be used. So I'm just conscious of time. We're going to move on to some more Menti questions now. So first one, how do you envision incorporating the findings and insights from today's discussion into your work or your organisation? Yeah, so that's definitely what we want, using it to support research grant applications, using it to get funding in order to fill some of those gaps in data. Becoming more aware of some of the inequalities in the profile and using that to support engagement. Advertising the webinars. So if we move on to the next question, just because I'm conscious that we want to have time for the Q&A and I've got a few more things to go through. So in what ways do you hope to see healthcare services become more inclusive and supportive? Yeah, so I think that person means in like interpreting services within healthcare, which is a massive issue in terms of language and health literacy and stuff like that being barriers to accessing health services. Having a better supply of interpreters is really important. Getting statutory services working more in the community. Yeah, loads of people talking about interpreting services, and yeah, moving beyond using white other as a category. That's something we're really keen to do as well. So if we move on to the final question, what other intelligence would be helpful to inform your work or improve your practice? Yeah. So know more information about which organizations and community groups tend to have the best contacts with the community and how to utilize those better. Yeah, just generally commissioning more projects with the Central and Eastern European community which is relevant to something I'll be talking about in a second. Understanding some of the cultural norms within the group. Yeah, okay, so there's a lot of stuff about working more with Central and Eastern European organisations and communities. So that introduces quite nicely the next bit. So I'm just going to talk a bit about some of the community engagement work we're going to be doing with the community over the next 2-3 years. So over the next 2-3 years, the communities team within public health are going to be commissioning and working with a series of deep engagement partners. And so there's going to be 18 available contracts covering 18 different communities of identity over 13 different lots. These are going to include communities based on ethnicity, religion, and faith, LGBTQ plus communities, and different people with disabilities. There's also going to be an academic partner that supports the partners by delivering training on community engagement and research, delivery of focus groups, and how to develop different evaluation tools and metrics. So there is going to be a Central and Eastern European deep engagement partner over the next 2 to 3 years. But if an organisation has limited capacity, we'll also accept applications for specific projects with the Polish community or with the Romanian community as well. The tender is currently live and is going to close on the 8th of May. And then we're looking to score and award that contract by the end of June and commence contracts by July. In terms of what the deep engagement partners are trying to do, we'll emphasize a two-way relationship between ourselves and the other partner. So the goal is improving public health's community intelligence and using community information to inform public health priorities. We're also going to co-create projects with communities to tackle health inequalities. And we're looking to improve community representation within council systems and bring community voices to inform strategy and policy development as well. And also to upskill and empower the community around public health. So in terms of how we're going to do that, there's going to be 4 focus groups per year with each community that will be led by public health priorities and used to fill some of the gaps in the data that I've discussed. And we're also going to have attendance of 5 council forums per year, such as the Creating a City Without Inequalities Forum or the Creating a Mentally Healthy City Forum. And that is going to help provide community voices or allow community voices to be in the room that's actually informing policy. We're also going to work to disseminate public health messaging within the community through a range of different channels. We'll also deliver 1 major public health intervention per year to address health inequalities, and that's going to be co-designed with the community. And there'll also be delivery of 4 training sessions for healthcare professionals per year, and as well as training on different community engagement skills and leadership skills through for the different communities. And yeah, we're going to encourage all of the different partners to collaborate with each other, as well as other community organisations, in order to effectively deliver the outputs of these deep engagement partners and to consider the intersectionality between the different groups. I've gone through that quite quickly, but somebody will put a link in the chat to the tender opportunity, and we'll be happy to discuss with people further as well. There's a range of other webinars on our other community health profiles that can be found on the Healthy Brum YouTube channel, as well as more webinars over the next month or so that you'll be able to see. And also we're conducting an evaluation of the profiles for University of Birmingham. So you can provide feedback on any of the profiles, and somebody will put the link in the chat to that as well. The purpose of the evaluation generally is to understand the role of the profiles that they can play, understand how different organisations are using the profiles, and how we can make them more accessible and suitable for different communities. Okay, I did that last bit quite quickly, but happy to talk about it more with people separately. That's the end of the presentation. So now we've got a bit of time for questions if anybody has any. And I'll turn the recording off in a sec as well if anybody wants to ask a question after recording. I've seen loads of stuff popping up in the chat while I've been talking, so I'll have a quick look through that as well. Also, if anybody just wants to turn their mic off and ask a question, please feel free.